Hey everybody, this is Miss McDaniels, and we're going to just hit some highlights of this diabetes presentation. I know it's a little bit long, but I just want to hit some highlights just to make sure that some points have been driven home. So make sure you understand diabetes. It's going to be a problem of hyperglycemia or the inappropriate metabolism of carbohydrates, fats, and proteins. Remember, there are two types, type 1 and type 2. Type 1, absolute absence of insulin. This again is going to be an autoimmune issue. For type 2, there's going to be a resistance to insulin and or a decrease in insulin production. Type 2, there can be a decrease again in the insulin. Cells can also become resistant to the effects of insulin, which makes it harder for glucose to transport into the cells. And so basically, if insulin decreases, it can lead to an increase in insulin resistance, or if insulin resistance increases, it can lead to a decrease in the insulin secretion from the pancreas. This graphic just kind of gives you a sense of what normal insulin metabolism looks like versus insulin resistance, and again, these are going to be your cells down here. Comparison, type 1 to type 2, make sure you kind of have a sense between these two. And unfortunately, like I talked in class, this says that the occurrence usually is of those 40 years or greater, but unfortunately there are more and more cases of children with type 2 diabetes. Common symptoms of diabetes, the 3 Ps, polyuria, polydipsia, and polyphagia. You need to kind of understand what they are in relationship to. Polyuria, polydipsia, and polyphagia can happen in particular to type 1 diabetics, because when the cells are starving and the body is not producing insulin, their body kind of gets a response that they need to eat more, but their bloodstream is getting overflooded with glucose, which makes them want to urinate more, that osmotic diuresis, and the increased urea leads to a sense of thirst. Other clinical manifestations, extreme fatigue, blurry vision, slow to heal, could be weight loss despite eating more, particularly with type 1s. Type 2s, tingling, pain, and numbness in hands and feet with the neuropathy are a little bit more prevalent, but that's typically because of the insidious onset of it. It basically takes a lot longer for someone to be diagnosed, so that damage can occur. But you will have long-standing type 1 diabetics that will also have neuropathy as well. So I hope that makes sense. This is a good graphic that goes over the negative feedback loop of what happens when there's an elevation of glucose in the body to versus what happens when there is low blood sugar. So make sure you kind of have a sense. This is just kind of the cycle of what happens with the body trying to maintain homeostasis, which I'm sure you're sick of hearing me talk about. This gives you a sense of what the body does when there is no insulin. Just kind of follow it. Hypoglycemia, osmotic diuresis leads to polyuria and glucosuria, which leads to dehydration and polydipsia. The other route is that the stars begin to starve, and which triggers the polyphagia. So it kind of explains the 3 Ps. Diagnosing, tests related to diabetes mellitus. Make sure you understand just the basic diagnosis. I love this slide. Simply, it really kind of talks to how unfortunate and how little patients may be aware of their current diagnoses, but their medications will say it all. It's not uncommon with those who are diabetic to have other comorbidities like hypertension, hyperlipidemia, obesity, hypothyroidism, and fatty liver disease. So it is your role, part of your role as a nurse is to educate patients. Risk factors: obesity, hypertension, sedentary lifestyles, hyperlipidemia, cigarette smoking, and first-degree relatives in terms of genetics. That's mom, dad, sister, brother. Certain ethnic groups are going to be at higher risk, and the history of gestational diabetes or delivering a baby over 9 pounds. Metabolic syndrome, if you ever hear that term, sometimes it may be a diagnosis of a patient, but it basically talks about a combination of different diseases that are going to be more related to those with type 2 diabetes. So a person doesn't need to have all these, but a lot of times you may see these different diseases going hand in hand. Again, you will not be tested on this. This is more for your information, so I will not spend any time on this slide. Diagnosing. Random blood sugar of greater than 200 must have signs and symptoms of diabetes mellitus. Fastings greater than 126, you have to be NPO, nothing by mouth, for at least 8 hours. Those are going to be your two typical ones. A lot of times they won't do post-load glucose testing, and for maternity, they do 1 hour and 3 hour glucose tolerance tests. That's for gestational diabetes. Further testing, the glycated hemoglobin, you might see it as HbA1c or A1c. This looks at an average blood glucose level over approximately 2 to 3 months. It will indicate glycemic control. 4 to 6 is good control for non-diabetics. Goal is less than 7 for diabetics, and greater than 8 indicates poor diabetic control. Urine testing, not for diagnosing diabetics. What it can be used for: testing for ketones, part of sick day rules for type 1 diabetics. Ketones are a waste product from fat metabolism. It can indicate impending ketoacidosis, and a lot of times patients who have type 1 diabetes should be checking when they are ill or have high levels of stress. And again, too, this one, don't overlook it. Remember when we talked about DKA, if a patient is under a lot of stress or has been very acutely ill, testing for ketones can kind of help them get a jump on preventing diabetic ketoacidosis. So again, you need to remember that process of DKA. Testing for renal function. If a patient has protein in their urine, it can be a possible indication of some damage that's going on with the kidneys. So it can show early changes within the kidneys. And sometimes too, if a patient has large amounts of glucose in their urine, it may just prompt a physician to say, hey, let's do additional testing. But again, you'll never use a urine test to say whether or not a patient is diabetic. Chronic complications from diabetes. Macro and microvascular, so big and small. This is a great slide. I love it. Macro, your brain, heart, and extremities versus eyes, kidneys, and nerves. And just think big versus small. And underneath talks about the manifestations you will see in terms of the damage caused by glucose, high levels of glucose over an extended period of time. Again, these are complications. They just don't happen overnight. It is a long exposure to hyperglycemia. Bill's story, I kind of blew through that slide, but you can watch that on your own. Chronic problems, again, here's some more pictures. It's basically like the last one. Large, again, brain, extremities, your heart, to your small of nerves, eyes, and kidneys. And when you think kidneys, like people immediately think like, well, the kidneys aren't that small, but it's not necessarily the kidneys. We're talking about at the glomerular level of the little filters that are in the kidneys, and that's what gets damaged. And that's why when we talked a few slides back about the protein spilling out in the urine is not just thinking about the kidneys itself, but at the micro level of those little filters that are getting damaged. This slide is pretty self-explanatory. Too much glucose over a long period of time just can lead to glucose toxicity. Macro. Now when we think macro, we're talking about all major blood vessels. Atherosclerosis is pretty prevalent with those with long-standing diabetes. There's a higher incidence of coronary artery disease and cerebral vascular disease. So stroke is more prevalent, and peripheral arterial disease, there's higher incident. Etiology, this all has to do with the epithelial cells. It releases substances that control the vascular relaxation and contraction, as well as enzymes that control blood clotting and immune function and platelets adhesion. So the result, basically, you'll get an increase in fibrogen, which will increase the platelet aggregation, and that will lead to the clumping of the small dense lipoproteins, which ultimately lead to the atherosclerosis. Macrovascular disease is the leading cause of death in patients with diabetes. Micro, again, remember, think teeny tiny. Nerves, the little capillaries, and nerves of the eyes, and again, like I said, the little filtration system in the kidneys. So, neuropathy, nephropathy, and retinopathy. Sensory, motor, autonomic. Again, you really have to start thinking from big to small in terms of the extent in terms of the nephropathy. So you can have numbness and tingling all the way down to the body functions of some of the larger organs in our body. For example, like the stomach that I talked about with gastroparesis. Other sensory nephropathy manifestations, you can have the hyperesthesia, which is basically increased sensitivity to stimuli. And this bottom portion, I've always said to make sure you understand that it does cause a type of pain, type of nerve pain, but understand that treatment is not always a pain medication. So patients may use anticonvulsants, tricyclic antidepressants, SSRIs, capsaicin, TENS unit, NSAID, tramadol. When we talk about anticonvulsants, there are medications like gabapentin and Neurontin, Lyrica, and with the tricyclic antidepressants, you may see things like Elavil, or the generic name for that is amitriptyline. Diabetes damages kidneys. Whether somebody is well controlled or not, over time, diabetes or the hyperglycemia will cause some damage to the kidneys themselves. So at the glomerulus is where basically the site of the filters, that is where the damage occurs, hence why that is where protein does not get reabsorbed in the body and spills over into the urine. A couple of tests that will check for damage: 24-hour urine collection or a random urine protein to creatinine ratio. Basically, you're looking, if it is positive, you are looking for those indications of microvascular changes. And microalbuminuria and proteinuria are the same thing. Again, look, another slide that is talking about kidneys. So please, I hope you understand that kidneys are an important thing to watch when it comes to our diabetics. Chronic hyperglycemia will cause damage to the vasculature of the kidneys and cause hypertension in the vessels of the kidneys. So the way that you want to help relieve some of that hypertension within the vessels, one, obviously, is prevention, well management of your glucose levels. But if medication is needed, ACE inhibitors have been found to slow the progression of renal disease. It can delay that onset. It doesn't affect a patient's blood sugar levels, and it will help lower that glomerular filtration pressure, which basically help slow the development of the renal disease, and make sure that you remember that ACE inhibitors end in pril. Motor neuropathy, when you're doing your skin assessment, head-to-toe assessment with patients, you may see some of the muscle wasting and imbalance of the intrinsic foot muscles, which come across as hammer toe or claw toe in your patients. And again, we talked a little bit in class that if you're seeing this, you need to address it, because this can unfortunately turn into a pressure ulcer, so you have to look at putting some sort of spacer in between the toes so you're not getting that pressure. Types of autonomic nephropathy, I talked about a little bit earlier, can be everything from gastroparesis down to erectile dysfunction. So outside of the peripheral neuropathy, that is pretty common. There are a lot of other effects to major organs throughout the body that having that chronic elevation of glucose levels can have a detrimental effect to the body. Peripheral neuropathy, big reasons. Why is it a problem? It can affect causing numbness or tingling. Patients are unaware if they've stepped on something. They can't really determine temperature changes. They have a hard time with proprioception. That's basically having a sense where they are in space, or they're going to be at higher risk for falls. They can have an unsteady gait, and sometimes have decreased deep tendon reflexes. Again, treatments are kind of the same when we're talking about neuropathy. Acute complications. We're going to talk about hypoglycemia and hyperglycemia. Hypo, blood sugar is less than 70. Signs and symptoms can be moderate to severe. Usually I say think of a person who's drunk. The reason why hypoglycemia is a problem is that the brain needs a constant supply of glucose. So that's why it's not best for you to starve yourself before coming to take a test with me. Hint, hint, have a good breakfast. And make sure it's a good breakfast, not one that's full of sugar. Treatment. Make sure you know treatment. Obviously, if a patient expresses symptoms, make sure you get a baseline, check their blood sugar. If it is low, you're going to load them with 15 grams of a simple sugar. That's equal to 1 carb exchange. Just think sugar. Sugar, sugar, sugar. These are all simple sugars. Check the blood sugar in 15 minutes and repeat the carbohydrate load until the person's blood sugar is greater than 70. Now let's say you give them the first load of 15 grams and it's over 70, then you're going to provide them with a snack of carbs and protein within 30 to 60 minutes to basically sustain the blood sugar. If not, they could crash again. If a patient is unconscious or unable to swallow, glucagon is what you'll give them. You're either going to give them sub-Q or IM. If the patient has an IV, you can give them 25 to 50 mLs of 50% dextrose in water via IV push at a rate of 10 mLs per minute. Diabetic ketoacidosis. The name says it all. Diabetic ketoacidosis. When I say diabetic, I think of hyperglycemia. When I see keto, I think of ketones, which is a breakdown of fats, and acidosis, which I'm thinking of metabolic acidosis. Also, when I think of diabetic, with that hyperglycemia, I'm thinking of some of the 3 Ps. So I'm really concerned that this patient might be dehydrated. With all those things in place, it should give you a good sense of how you need to treat them. Symptoms. Their blood sugars are greater than 250. Their pH is less than 7.35, positive for serum ketones. Metabolic acidosis, Kussmaul respirations, rapid and deep. Their breath is going to be fruity. You're going to see some metabolic changes, increased K, and some other electrolyte differences. There's a lot of different symptoms that go along with DKA. A lot of the patients that I've dealt with, some of their Symptoms that they always remember having are nausea and vomiting and some stomach cramping. Etiology, it can mainly occur with type 1s. It can also occur with newly diagnosed with type 2s, and it's usually brought upon by an infection, trauma, increased stress, or simply non-compliance. Again, this kind of hits on again what happens when a cell starves and how it leads to acidosis. Treatments. IV fluids. Monitor to avoid cerebral edema. You don't want to push the person into hypovolemic shock. Normal saline to replace lost fluids. Potassium replacement and insulin you need to start via IV. Regular insulin. Do not give this person a sub-Q shot of insulin. And treat whatever that underlying problem is. This gives you a sense of what happens before treatment. So here, when a person is becoming acidotic, the body is trying to correct itself. So it's trying to push these hydrogen atoms out from the bloodstream into the cell, which unfortunately raises a person's potassium levels. That's why you sometimes see elevated potassium. During treatment, giving a patient insulin, it will not only push the glucose back into the cell, but it will also take potassium along with it. That's why you do need to monitor a patient's potassium while you're actively treating them for the hyperglycemia. The other issue that we see is hyperglycemic hyperosmolar nonketotic syndrome, HHNS. There are a lot of different ways to say it, but the names say so much. So again, hyperglycemic, going to have high blood glucose levels. Hyperosmolar, that right there is telling you that you're having, the patient's going to have a high osmotic level, which should right away say to you, oh my God, they are probably going to be dehydrated. Nonketotic. That is super important to know because this person is not creating ketones. So therefore, they are not going to be in metabolic acidosis. See, you can learn a lot by just understanding the name of a disease. It is serious life-threatening condition. The person can have hyperosmolarity greater than 350 and have sugar levels greater than 600. These are insanely high glucose levels. Usually occurs in elderly that either don't have a history of diabetes or are type 2 diabetic. Again, underlying cause, infection, stressors, surgery, or dialysis. Also, poor fluid intake can be an issue as well. Symptoms, hypertension, profound dehydration, really important here. So make sure you know your signs and symptoms of fluid volume deficit or hypovolemia, okay? Coexisting cardiac and renal disease, and that has a lot to do just because of the population. Again, high glucose and high serum osmolarity, and electrolyte and bun levels typically will be consistent with that of somebody who's dehydrated. So, the big question a lot of students will ask is, how does HHNS differ from DKA? And what we have in red, that basically HHNS lacks acidosis, serum or urine ketones, and no abdominal pain. Well, why is that? Because insulin levels typically produced are too low to prevent hyperglycemia, resulting in osmotic diuresis, but are high enough to prevent fat breakdown. So where in DKA, no insulin is present and promotes the breakdown of stored glucose, protein, and fat. So that's why you don't have the same symptoms. Treatment, gentle rehydration. Typically, this patient population is older and might have a difficult time and be more subject to fluid overload. Correct any electrolyte imbalances, insulin to treat the hyperglycemia, any underlying medical condition, and a lot of it might also be education and how to teach the patient to check their blood sugar to prevent a reoccurrence of this. So education for patients. This is so important, and a majority of the stuff you really do need to know. Foot care sick day rules, that's going to be for your type 1 diabetics primarily. Know who's at risk for diabetes mellitus, and understanding medication interactions with those who have diabetes, in particular steroids, so they will need to have increased monitoring of their glucose levels. Foot care, you need to know it. Inspect feet daily, wash feet, pat dry, avoid lotions between the toes. You want socks that basically pull moisture away from it, so cotton or wool. Don't cross at the ankles, because again, a lot of diabetics have issues with circulation. Don't remove calluses or corns by yourself. Obviously, in neuropathy, they're not going to be able to feel and possibly cause themselves injury. Nail care after a bath when the toenails are soft. Nurses are not to cut patients' nails. Usually has to be done by a podiatrist, but if they do cut their own, they need to cut straight across the nail, no curving, and separate overlapping toes with cotton or lamb's wool. You need to know all this. And again, because of neuropathy, they may need to test water with a thermometer or with an elbow before washing their feet. Additionally, avoid open-toe shoes. Wear shoes that fit correctly. Wear slippers with soles. Do not go barefoot. And this is the clean absorbent socks. Do not use hot water bottles or heating pad on your feet. Avoid prolonged sitting or crossing of legs. Cuts need to be cleaned immediately with warm water and mild soap, and gently patted and dry in dressing, and seek and watch healing. If a patient does not start to see healing within about 24 hours and redness and a warm feeling around a cut seems to occur, they need to call their provider right away. Sick day rules. This is going to be primarily important for type 1 diabetics, but it can also be important for type 2 diabetics as well. It all kind of depends on their insulin resistance. So they need to watch their blood sugars every 3 to 4 hours, continue to take their insulin or hypoglycemic agents, increase their fluid intake to prevent dehydration, make sure that it's not full of sugar, maintain nutritional needs through soft foods and liquids. Type 1 diabetics should test their urine for ketones to make sure that they're not putting themselves at risk for DKA, and rest. They need to call their provider for certain things. 1, blood sugar is greater than 240. Fever that is greater than 101.5 that does not respond to Tylenol or last for more than 24 hours. If they feel disoriented or confused, if they're starting to have rapid breathing, vomiting more than once, diarrhea 5 times or more within 24 hours, if they can't tolerate liquids, or that the illness seems to go on for more than 2 days. And what I want to show you here, this is an example of a type 1 diabetic that I had. And if you see Monday through Wednesday, they're on their normal course of insulin, and all of a sudden they have strep throat and are starting treatment of amoxicillin. And you can see quickly how illness throws this patient's insulin resistance off. And so all of a sudden their numbers are out of whack, and after being on antibiotic for 3 days, come day 4, their numbers improve. And what I learned with this particular patient, this patient was a nurse herself, and I remember talking to her and say, why did you not increase your insulin since you were ill? And she just kind of forgot about it, she told me. And so that kind of reminded me that despite how long a patient may have been a type 1 diabetic or type 2 diabetic, re-educating them and reminding them how they need to manage certain things, especially at time of acute illness, never hurts. So don't assume. Steroids and hyperglycemia, oral steroids like hydrocortisone can increase cortisol levels in the body, which stimulates gluconeogenesis in the liver, and also inhibit insulin production, which unfortunately will lead to elevated blood glucose levels. So if you have diabetics that are on a course of steroids, let them know that their blood sugars are going to go up and they may need to adjust their insulin accordingly. Life changes for clients with diabetes. We're going to talk about nutrition and exercise. Make sure that they understand they need to have a good balance of proteins, carbs, and fats. Fiber, alcohol, too much can increase the risk for DKA. Sweeteners are okay in moderation. And to watch misleading food labels. So make sure that patients understand serving sizes when they are looking at food. So for like example, this is 10 servings. So kind of have to multiply, one serving size is 10 crisps. So really if they eat this whole bag, you kind of need to multiply this carb here by about 10. And that is a lot. So patients need to understand how to read labels. In terms of alcohol, diabetics don't have to cut out alcohol altogether. It needs to be done in moderation. Exercise, consistent exercise, same time each day, same amount, same intensity. If there's really any change to this, they have to be mindful about having a snack before they exercise then. Don't exercise while they're sick. If a patient's at a risk for hyperglycemia, they may need to have some screening done before they start an exercise regimen. But the reason why about consistency is that our body kind of gets used to a routine. So any fluctuations in it, it doesn't know how to respond properly. So again, same time each day, same amount, same intensity. Risk for post-exercise hypoglycemia, those who are at risk, make sure to educate them about having a snack beforehand or after. Insulin and diabetes. Make sure if you have a new diabetic that they know how to administer insulin. Unfortunately, a lot of times I don't think education is done very well in this department. Usually given sub-Q. Preparing for injections, only NPH needs to be agitated. It should be gently rolled between the palms. All other insulins should be clear. Don't use if there are any particulates or clouding in the insulins that are not NPH. And the rubber cap needs to be clean. Skin should be clean with alcohol or soap. Make sure you know your onsets and peaks and durations of your rapid, short, intermediate, and long-acting insulins. And make sure you know what insulins go to in each category. Some tips of how to remember long-acting, your Lantus and Levemir, start with letter L. Intermediate, NPH or Humulin, N, NPH. Intermediate. Short-acting, Humulin R or Novolin, which is going to be your regular insulin, and your rapid-acting are your Humalog and Novologs. Different sites for administration, and each site actually has a different absorption rate. Abdomen is the fastest, your arms are the second, the thighs are the third, and this flank buttock area is going to be the slowest in terms of absorption rate. Injection sites, again, fastest to slowest. Make sure your patient rotates their sites, and that will help to avoid some complications. Make sure you know what syringe your patient should be using. Needs come in different unit sizes. Use the appropriate one. Don't use a 100-unit syringe for a 10-unit dose. Needles come in different lengths. Shorter needles with patients that have less adipose tissue. And syringe and needle and pen injectors should not be reused. I always show this picture because when I have, not just with insulin, but when you are drawing up medication for patients, if you have an opportunity to switch your needles before you inject the patient, it makes it as a better experience. So if you can, I use a different needle that I drop the medication versus the one that I inject in a patient. And this is why, because it shows how nice a needle looks when it's brand new. This is after 1 use. After 2 uses, and after 6 uses. So if you think you drip some medication but realize after you pulled it out of the plunger that you didn't get enough, so you stick it back in, now you've kind of used it twice. This is what it starts to look like before you actually inject it into the patient. That's why they're going to feel the needle. So if you can use a fresh needle that you actually inject in your patient, is going to be a much better experience for them, and they probably will not feel it. Injection devices, insulin pens, they're great. They're preloaded. They have easy dial-up dosing, and they're really super convenient. For long-standing diabetics, though, their insurance may not cover them. Insulin pumps. They're honestly not just made for type 1 diabetics. I've heard of some really uncontrolled type 2 diabetics use them. But important points you need to know about insulin pumps: the infusion set needs to be changed every 3 days. Insulin levels drop quickly if the infusion is interrupted. A lot of times patients have a continuous basal rate that runs with boluses at meal times. Highest risk for hypoglycemic emergencies, so patients need to be taught how to self-monitor. They need to know how to work their pump, adjust settings, and how to respond appropriately to alarms. Ketoacidosis typically occurs with patients who have pumps because of inexperience, infection by not changing their site, if there is a kink in the tubing, dislodging of the needle, or if there's a pump malfunction. And this just kind of gives you a sense of where the catheter is going into the fat area with a pump. Side effects of insulin: local allergic reactions, and a lot of times the reactions I've seen with patients isn't to the insulin itself, but the preservative within the insulin. Systemic allergic reactions, those are typically rare. Lipodystrophy and lipoatrophy, which is a decrease when using, usually is decreased when using human insulin, and rotating the sites, and giving insulin at room temperature. So that's basically the lipoatrophy is going to be loss of sub-Q fat at the site, dimpling, like you see right here. And then the lipohypertrophy, that's where you're going to see a little bit of a fatty mass or hardening. So you're going to see a raised hardened tissue, which I really couldn't find a good picture. So ways to avoid that is using human insulin, site rotation, which is a big one, and of course giving insulin at room temperature versus cold insulin. So insulin therapy side effects. So some issues that some patients might run into is morning hypoglycemia. And there's 3 different types that you may hear. Insulin waning. This is going to be a progressive rise in blood glucose from bedtime to morning. Treated by increasing the evening, either pre-dinner or bedtime dose of intermediate or long-acting insulin, or institute a dose of insulin before the evening meal if one is not already part of the regimen. Dawn effect, we typically see these with type 1 diabetics. This is where there's an elevated blood glucose at around 3 o'clock. Usually it's related to a release of growth hormone secreted near dawn. Treatment is early morning insulin dosing or change in injection of evening intermittent insulin or dinner time to bedtime. A lot of times what I may see with this, with type 1s who have a pump, they might just have a different basal setting around this area of morning to make adjustments for it. Somolgi effect, this is morning hyperglycemia in response to nighttime hypoglycemia. I'll see this sometimes, another term a lot of doctors may call this is just rebound effect. This is, again, where the body just kind of responds to having a low. It's usually treated by evening snack or decreasing the amount of insulin at night. Now here's something interesting, and this is just kind of a side thought. I've talked a little bit how stress can make the body more insulin resistant. So, cortisol levels are lower at night and rise in the morning based on our sleep cycle. So if you think about cortisol levels also being elevated in the morning, will also have some impact on patients being hyperglycemic. Interesting thought. So there are a lot of different hormones in play here. So this slide, I'm just showing you, you might see more patients. A new technology out there is the continuous glucose monitoring, and what you just need to watch, especially if you work in outpatient settings, is you see here they have an infusion set that is very similar to like a pump that goes into the sub-Q that kind of helps with the monitoring of their blood glucose levels. So obviously if you see this in their upper arm, you cannot do blood pressure there. But just to let you know, it's out there. The two main ones right now are the Libre and the Dexcom. For those who want to go into OB, right now Dexcom is the only one used in pregnant patients. But you'll see a lot of them with the Libre. So again, you're not really going to be tested on this, but just to let you know that it's out there. I don't know if you have any questions, but if you do, we will certainly cover them in class. That's a wrap.